Welcome to the Patients Rising Education and Training Program for Technology Assessment Standards in Value Claims for Pharmaceutical Products and Devices. My name is Paul Langley. I'm a health economist and adjunct professor in the College of Pharmacy, University of Minnesota. I would like to introduce you to an education and training program that has one objective: to overcome 30 or more years of pseudoscience in health technology assessment, characterized by the construction of imaginary claims based entirely upon assumptions. We use the term pseudoscience advisedly, and this applies to claims presented by the Institute for Clinical and Economic Review and now by the CHEERS 22 guidance. Also included in here would be the International Society for Pharmacoeconomics and Outcomes Research, as well as globally a number of health decision-making groups who use the same methodology. So let's repeat, why pseudoscience? The analytical framework that supports health technology assessment, the creation of assumption-driven simulations for hypothetical target patient lifetimes, fails the standards of normal science. The value claims, including blanket claims for cost effectiveness, are not credible, empirically evaluable, or replicable. Meeting these standards is the essence of the scientific approach to the discovery of new facts. In effect, ICER and ISPOR, in their presentations, in their practice standards, fail the demarcation test between science and non-science. This relegates our current approach to health technology assessment to the category of intelligent design. Assumption-driven simulations are unacceptable. Health technology assessment, interestingly enough, is the only social science that relies on invented claims for its contribution to formulary decision-making. This is by design and was proposed by leaders in the field some 30 years ago as a way of avoiding a structured research program to meet evidence gaps for new therapies. These criticisms are not new. They go back over 30 years but have been ignored. It is time HTA accepted the required standards, including fundamental measurement, for a meaningful assessment of response to therapy. Health technology assessment has relied on imaginary pseudoscientific claims for over 30 years. The program we are to present puts forward the case for a new start in health technology assessment and formulary submissions. Rather than invent claims which, by definition, are non-evaluable, we must focus on claims that can support formulary decisions. Otherwise, there is no room for health technology assessment apart from being an academic exercise to create more published papers. We cannot base therapy pricing and access on invented evidence of the type produced by ICER. This is just simply unacceptable. We will, undoubtedly, face an entrenched opposition. Too many people have too much to lose. This includes not only organizations such as ICER and ISPOR, and most recently those journals and individuals who have endorsed the CHEERS 2022 guidance, but also the hundreds, if not thousands, of students and academics who have contributed to multitudes of papers using assumption-driven simulations. At the last count, there were some 19,000 published papers in the last 30 years which have used some variation of assumption-driven quality of life simulations. We don't require a guide to imaginary modelling such as Cheers 22 to be submitted to leading journals who should know better. To support New Start, we need to document the manifest deficiencies in the health technology assessment model, epitomized by the ICR modelling for evidence reports, notably the failure in measurement theory. We must focus on evaluable claims, not on guesswork. This educational program has 4 objectives. These are, as detailed on the slide in front of you, first of all, to present the requirements of normal science for the evaluation of value claims for pharmaceutical products and devices. This involves the concepts of credible claims, empirical evaluation of claims, and the replication of claims. And these all apply to single claims or single value claims for target populations in disease areas. The focus here, it must be emphasized, is on the disease area, the target patient population for the therapy or device of interest, which is going to be evaluated and reported. The second objective of the program is to detail the manifest failings, and there are many, of the current approach to inventing evidence for value claims. This is not just a critique of assumption-driven lifetime simulations, but also the emphasis on the quality-adjusted life year, the QALY, in those modelling endeavours. The key point is that the QALY is a mathematically impossible construct. It should be junked. It has no relevance whatsoever in therapy response. Certainly, there are alternative ways of coming with something which might approximate a QALY, but the way the QALY has been developed with generic preference scores is simply nonsensical. Third, we propose to abandon modelling in health technology assessment. This might appear to be a really strong case to make, but the point is that if you model and you collapse everything into a single metric, such as cost per QALY, there is no way you could ever empirically evaluate that claim. So we need to abandon models unless these models are relatively short-term and they embody evaluable claims which, if they fail, can then be reassessed in terms of the assumptions that you've built into that short-term model. This is the essence, if you like, of the scientific method of conjecture and refutation. Finally, we propose to detail the required standards for all value claims in terms of the axioms of fundamental evidence. That is, where we identify levels of evidence for statistical analysis, nominal, ordinal, interval, and ratio, where all claims are defined as single attributes. And for those attributes to be actually useful, they have to have ratio or interval level properties. We discuss these issues in more detail, obviously, in the program itself. At the same time, all value claims must be supported by evaluation protocols. This is something which is missing entirely from health technology assessment, obviously because you can't propose a protocol for evaluating an impossible claim. And of course, these protocols are specific to value claims in disease and therapy areas. The New Start approach to formulary submissions and value claim evaluation rests upon 2 premises, where each value claim, as we've already indicated, is accompanied by an assessment protocol. These premises are, first, all value claims for a product or therapeutic intervention must refer to a single attribute. that meets the demarcation standards for normal science. All value claims must be credible, evaluable, and replicable. The notion of a single attribute is critical because we want to ensure that the measurement properties are appropriate and that we are actually measuring what we are intending to measure. The second premise is that all value claims must be consistent with the limitations imposed by the axioms of fundamental measurement. This is critical. If you can't measure something properly, then you shouldn't bother to measure it at all. And this is the problem that health technology assessment faces. If you build models on assumptions, if value claims are built on assumptions, then you have nowhere else to go, because as we detail, any series of assumptions can be used to develop any particular model. There could be a marketing exercise, which unfortunately so many of these simulation models have been in the past, where journals have accepted them without asking the question, why are we only accepting or being submitted papers which support the product for the funding manufacturer? There's endless examples of this where journals such as Value in Health and the Journal of Medical Decision Making all capture articles, but the majority of those are favorable to the funding body. So finally, therefore, all value claims must be consistent with the limitations imposed by the axioms of fundamental measurement. They must meet interval or ratio measurement standards. The term 30 wasted years is used advisedly. We have indeed wasted 30 years in health technology assessment. Looking back over the thousands of papers and reports that have been written and decisions by groups such as the National Institute for Health and Care Excellence in the UK, all of them rely upon imaginary constructs. Indeed, NICE in the UK is interesting that it has a series of guidelines, and these guidelines are enforced by academic centres that have devoted years of their lives to evaluating imaginary claims. And if they don't like one set of assumptions or one set of imaginary claims, then they propose an alternative one. The fact that you can go on forever inventing one series of claims after another by changing assumptions doesn't appear to have resonated with them. In the early 1990s, and it's well documented, the decision was made that in order to make the case for new pharmaceutical products at product launch, hypothesis testing has to be abandoned in favour of creating approximate information to support formulary decisions. The reasons for this, in part, are that evidence is fairly limited for new products. They've just received FDA or EMEA approval, and they are resting on pivotal clinical trials. There are evidence gaps, there are questions which need to be resolved, and one way of doing this is to actually sit down and develop a research program which may extend for a number of years into the future, right? But the alternative, which is a lot easier and obviously a lot more viable in terms of generating consulting income, is to simply put hypothesis testing to one side and just build models on the basis of a series of assumptions. So we reach the stage where what ISPOR describes as approximate information, whatever that term means and what is it supposed to be approximate to, an unknown future presumably, is the keystone, is the cornerstone of health technology assessment. So what we've actually been doing is chasing this will-o'-the-wisp of imaginary claims. This is the fundamental error in health technology assessment. By design, the standards of normal science, conjecture and refutation, have been ignored, deliberately ignored. This approach was accepted by proposed and accepted by leaders in the field and detailed in textbooks and practice guidelines. In fact, one of the leading textbooks in this area is nothing more than a primer for inventing imaginary claims. Unfortunate, but people rely upon it, and they are led, I think, to this incorrect conclusion that health technology assessment can rest upon imaginary claims. Also, this approach was accepted uncritically by academic centres, government agencies and analysts, despite numerous warnings to the contrary for those who respect the standards of normal science, which have been in place for over 300 years, and also by measurement theorists who have pointed out that nobody actually paid account to the axioms of fundamental evidence in developing preference scores. So the result has been, over 30 years, the acceptance for publication of thousands of cost per quality imaginary claims which completely fail to meet any semblance of the standards of normal science, hence the term pseudoscience. Health technology assessment, if you like, joins intelligent design in the Dover courtroom. And we are still locked into this analogue of intelligent design with the recent publication of the CHEERS 22 guidance for submitting imaginary model claims to academic journals. This might seem a little strange, but it's been endorsed by 15 leading journals and by hundreds of academics. You only have to look at the way in which it is structured. It completely ignores standards of normal science, it completely ignores measurement theory, and it completely ignores the information that might be relevant to formulary committees in making pricing and access decisions. Of course, model claims can be defended by scenarios and sensitivity analyses, and that technological proposal for probabilistic sensitivity analysis. This is simply a smokescreen. Any model can be defended by scenarios, by probabilistic sensitivity analysis. The point is that the evidence presented, the value claims, the claim, if you like, that a product is cost effective are entirely imaginary. They can never be empirically evaluated. What this means, therefore, is that we need a new start, a solution which involves rejecting model claims for therapy benefits if the claims fail to be empirically evaluable in a meaningful time frame. We reject claims that fail the standards of normal science in favor of attributes supported by evaluation protocols. This education and training program is based upon 14 modules in 3 groups. The first of these modules is to look at the standards for normal science. This is something which should actually be taught in all graduate courses, at least in health technology assessment, but seldom is. So we have so many students being graduated who have little, if any, idea of the standards of normal science, of measurement theory, and even, to be philosophical, the concept, the problem of induction. So the first of these modules, which is looking at the standards of normal science, looks at first science versus non-science. What are the criteria that differentiate science from non-science? The demarcation criteria. And the fundamental issue is one of evidence and whether that evidence is credible and whether that evidence leads to value claims which can be evaluated. Absent the concept of appropriate measurement and then the empirical evaluation of these programs, of these statements, of these claims, we are forced into the non-science category. The second module addresses some key issues in measurement theory. The failure, going back to the 1980s, in developing generic multi-attribute preference scores was that nobody really thought in any shape or form about measurement theory. What are the axioms of fundamental measurement, and what limitations do they impose on the instruments you are proposing to develop? The key issue is, if you want to develop an instrument with a ratio or interval measurement property, then the instrument has to be designed from the get-go to actually create those measurement standards. The multi-attribute utility programs, the scores, the preference scores, standard gamble, and time trade-off all fail the standards of fundamental measurement. They only produce ordinal scores. And this is a critical failure, because an ordinal score as a preference score cannot support response to therapy. We have no idea of what the psychometric difference is between adjacent scores, if we rank these scores, and the only way in which we can evaluate those data are through non-parametric statistics. The third module looks at the problem of induction. As we've noted in previous slides, assumptions are the critical input to modeled claims, and these assumptions can refer to the model structure as well as particular inputs and parameters within the model. Hume's problem of induction, which was first stated in 1748, has been a perennial problem in philosophy. It says quite clearly that you can't look to the past to support assumptions about an unknown future. Very simple, but what it means, and interestingly enough in the sort of wider area of scientific laws, is that the fact that a law has worked in the past, the fact that the sun has risen every morning for millions of years, does not mean that it's going to rise again tomorrow. That's a logical fallacy. However, we find in model building and in the various textbooks an implicit assumption that we can talk about realistic assumptions, that we can develop a structure for the model which is realistic. We can actually collect assumptions and then populate the model with those assumptions which are realistic, and then come up with a realistic claim for value and pricing and access to therapy, which extends decades into the future. This is complete nonsense. Certainly you can say, I think, or I prefer one assumption to another, but that is a question of psychology. It's not an issue of logic. We cannot base in logic assumptions about the future on evidence from the past, irrespective of how likely it is that that previous assumption will continue to hold. We cannot make that assumption. Finally, Module 4 looks at the recently published CHEERS 22 or CHEERS 2022 guidance for submitting your imaginary claim to leading academic journals. Now, presumably, because CHEERS 22 has been endorsed by a number of journals, editors are quite happy to accept these. So we have to look forward to a future, an endless future of imaginary, non-evaluable claims for pharmaceutical products and devices. No hope at all of evaluation. It is actually an analytical dead end. It's barren. It goes nowhere. All we do is just create one more modeled assumption, set of assumptions after another, supported, I might add, by the readily availability of software packages. Plug in your assumption, create a new value claim. We're not asking for it to be in any way empirically evaluable, but just something which we can send to a journal and improve the list of references in our CV. The second set of modules in this program looks at the failure of approximate information. This is important because the notion of approximate information, which is supported by leaders in the field of health technology assessment, has been with us for 30 years. Why? Well, in the early 1990s, the decision was made to abandon the standards of normal science in favor of approximate information modeling. Why? Because on the one hand, there is limited evidence for new products when they receive marketing approval by the FDA, but also because no one was prepared to sit down and put together a research program to address evidence gaps, requirements for new information, which may extend over a number of years. The easy way out is to invent models, to invent assumptions, and to convince formulary committees, including major government organizations such as NICE in the UK, that this is the way forward. The leaders in the field who are advocating approximate information have and continue to have a significant input to policy making. They make the claim that this is the way forward, there is no option, and that this is how we should judge resource allocation in healthcare systems. The first of these 5 modules looks at health technology assessment as a belief system, as a meme, if you like, akin to a religion, a belief system which relies upon a consensus view, a consensus acceptance of claims, which may be false, but that doesn't matter, where truth is consensus, where people believe in the QALY because they are told to believe in the QALY. There's no room for criticism or independent assessment. You are locked into that belief system. Indeed, if you do try to escape, you may even have your career seriously threatened. If everybody bases publications upon imaginary outcomes and journals and governments accept imaginary outcomes, he who stands up and says the emperor has no clothes has a problem. So this raises some philosophical issues in terms of when truth is not consensus and how we should evaluate statements which support this odd view of the world. The next system we look at is multi-attribute generic preference measures. These include the EQ5D, 5L, 3L, HUI, Mark 3, Mark 2, and so forth. And these are all, and of course the standard gamble and the time trade-off. These are all failures. They fail because they are, in fact, multi-attribute. You can't combine symptoms and response levels to those symptoms in a single measure, because the only way in which you can do that is by aggregating over ratio measures. An example would be the body mass index, which comprises 2 ratio measures, height and weight, okay? And therefore the BMI also has ratio measurement standards. The multi-attribute instruments are simply valued collections of symptoms and response levels. They only produce, through the various algorithms, preference scores which have ordinal properties. And ordinal properties cannot support any of the arithmetic operations such as multiplication, division, addition, and subtraction. Also, because these scores are comprised of a cap at unity, and then you have decrements in utilities giving you a score less than unity. Unfortunately, they typically overshoot. That is, you would like everything to be between 0 and 1. You would like this to be a bounded ratio measure. You would like this to have interval scoring properties, which is implicit in the ratio measure. You don't want negative values. The problem is they do have negative values. And however you try to tweak the econometrics or the equations, you end up with negative values. In fact, the EQ 5D 5L is a horror story in this respect. In the US, 20% of health states using the EQ 5D 5L have negative scores. And this leads us in Module 7 to the impossible QALY. Quality adjusted life years have been with us for 40 years. They are favored because they attempt to capture in a single metric all of these various attributes of health-related quality of life. They produce claims which are non-evaluable, but more importantly, and this is what is overlooked by many of the criticisms of the QALY in terms of age of the patient, whether it's ethical, whether it's equitable, and so forth, is that the QALY is based upon multiplying time spent in a disease state, which is obviously a ratio measure, as you can have 0 time, by a ordinal measure. And this ordinal measure cannot support multiplication. So the preference scores, which are then multiplied by time spent, are impossible scores. This is a mathematically impossible operation. And this leads in Module 8 to impossible value claims. If the QALY is an impossible mathematical construct, then any claims for future cost per QALY, incremental cost per QALY, threshold cost per QALY are meaningless. So the impossible value claims stem directly from 1, the assumption-driven modeled world, and secondly, a mistake in interpreting or applying fundamental measurement. And the reason for this is quite straightforward. When these various multi-attribute instruments were developed in the 1980s and launched in the early 1990s, nobody thought about measurement theory. Nobody thought, there were 1 or 2 exceptions, they really didn't resonate, nobody thought that if you want an instrument which is to have ratio properties, proportions bounded by 0 and 1 to create QALYs, then that instrument has to be designed from the get-go to have those properties. Nobody thought about it. And finally, Module 9, this leads to the notion or the proposal to abandon models in value claims. Lifetime models, the ICER business model, the reference case models, are completely irrelevant. They add nothing to our understanding of the real world. They, in fact, can be entirely misleading in resulting in formulary decisions which are not favorable towards patients, physicians, caregivers, and so forth. So we abandon model claims in favor of value claims based upon single attributes. The final part of our program looks at a new start in health technology assessment. This is not new. People have been proposing this for many years, but what we need to do is to say that New Start is not difficult. New Start is actually very straightforward. It means we step back from all of these multi-attribute modeled assumption-driven simulations with probabilistic sensitivity analysis, which are entirely meaningless, and focus instead, for the purpose of informing the formulary committee, on the attributes which we think are important for that product in that therapeutic area. and this indeed may reflect requirements from the formulary committee as to the value claims that they consider to be important and and the type of value claim that the manufacturer should ensure is embodied in its development program. There are 5 modules that we propose here. First of all, the essential guidelines for value claims in formulary submission. What should be the standards? Should we think about a guideline for formulary committees? What are the standards that a formulary committee should expect from any submission that is made by a manufacturer to that healthcare system? And that comes back to the 2 fundamental premises of the New Start: the single attributes, the role of measurement theory, and the ability through protocols to evaluate those value claims, whether they are clinical, whether they are patient-reported outcome, or whether they rely on claims for resource allocation, resource utilization, including, for example, compliance and switching with therapies. The second module focuses on something which is essentially entirely overlooked in health technology assessment: the patient voice. What role should the patient have and the caregiver in developing, in this case, patient-reported outcomes which are empirically evaluable? We face the problem, well, we don't face it, health technology assessment faces it, that the majority of patient-reported outcomes, whether they are generic or disease-specific, fail the standards of normal science. They are all ordinal, and we address that in Module 12. But as far as Module 11 is concerned, we look at a particular attribute: need fulfillment. To what extent are patients' and caregivers' needs fulfilled in a particular disease area, where health is obviously a key ingredient in need fulfillment, but not just a focus on health-related quality of life, but on the broader concept of quality of life. And there are, in fact, techniques using rash measurement theory to actually develop need fulfillment instruments which meet all of these requirements. And in fact, as we detail, some 30 or so instruments are available, but typically ignored. Okay, then we go to PRO claims, patient-reported outcomes. There are hundreds, I won't say thousands, but hundreds of patient-reported outcome instruments. Many of them used only once by the authors, but many of them used fairly widely. The problem is that unless the patient-reported outcome instrument, like the multi-attribute instruments, which are of course patient-reported outcomes, unless these are designed to have the appropriate measurement properties, then you are promoting one more ordinal instrument, one more claim which has no meaning in terms of response to therapy. Module 13 looks in more detail at a formulary submission guidelines document which has been produced through Patients Rising and the University of Minnesota to set quite clearly the standards for formulary submissions. And this leads in Module 14 to questions that a formulary committee should ask of manufacturers. Before submitting, at the formulary committee's request in the US, before submitting a submission to support value claims, the manufacturer should be asked to complete a series of questions. And if those questions have been completed, then the submission should be made. This is a very important step because formulary committees don't want to spend their time rejecting submissions from manufacturers and others that simply want to replicate what they've been doing for years with NICE and other agencies which accept reference case arguments. And that's the program. If you want further information, the details are available, and if you wish, you can download the slides and you can download a series of notes. And this slides and notes actually accompany this, and the notes include further references. Thank you very much for your attention.